COVID-19, a bit of a pop-up session, what healthcare providers should know. My name is Nicole Ammon. I am a clinical assistant professor of psychiatry at NEOMED, and I'm going to be your facilitator today. So the way that we're going to run today's session is I'm going to ask the panelists to unmute and introduce themselves one by one. And then we're going to have a presentation by Dr. DeLucia and Dr. File. Throughout the presentation and afterwards, please, any questions or comments that you have, type them into the chat box so that we can tackle those after the presentation is over. If somebody is working with a specific patient that has COVID-19 and you would like to talk about that patient, please do put that into the chat box so that you can let us know and we can work with you one-on-one in the chat to figure out what's the best way to go about that. So again, my name is Nicole Ammon. We're going to go through some introductions, starting with Dr. File.
Well, hi, my name is Tom File. I'm chair of the infectious disease section at NEOMED, also chair of the infectious disease division here at Summa Health in Akron, Ohio, and happen to be president of the Infectious Disease Society of Ohio. So it's good to be with you today.
Thank you. Dr. DeLucia?
Hello, my name is Angelo DeLucia. I'm a professor of molecular virology at Northeast Ohio Medical University, and I've been teaching about these viruses for quite some time, and am anxious to let you know of a few things about them today. Thank you for showing up.
Thank you. Dr. Mystery. You are muted, so let's start that over again, please.
Marco.
Very good.
There we go. Again, my name is Bhavin Mistry. I'm an infectious disease pharmacist at Cleveland Clinic Akron General, as well as an assistant professor in the pharmacy practice department at NEOMED.
Welcome. Thank you very much. Dr. Dougal?
Yep.
Hello, I'm Jennifer Dougal. I'm the director for the Center for Student Wellness and Counseling Services at Northeast Ohio Medical University.
Thank you. Dr. Wayne?
Good afternoon. Matt Wayne. I am an internist and a geriatrician, and currently I'm Chief Medical Officer at Communicare.
Thank you. Joan Hall?
Good afternoon. I'm Joan Hall, and I'm the epidemiologist with the Communicable Disease Unit at Summit County Public Health.
Thank you. Is Dr. Bauer with us today from Akron Children's? Looks like that didn't work out for his schedule. Okay, so we will go to Donald and Jessica.
I'm Lewandowski. This is my wife, Jessica Wong. And we are residents of Wuhan, or we were. But yeah, that's us. Nice to meet you.
Thank you for being here with us today. Thank all of you for being here with us today. Before we get into the didactic, I do want to let you know, please, again, use the chat box for all questions, comments throughout the entire session. And we will have time to talk with each of the individual panelists and get to whatever you're thinking about or whatever concerns you have. If you have technical issues, we have lots of people joining us today that are going to be tech support. So Emily Murphy, Jessica Savala, Jamie Brewer, Denise Kropp, Kay Seibert, you'll see somewhere in here is Project Echo Continuing Education, Haley Farver. I'm probably forgetting somebody because this has been a huge team effort that I really just want to thank all of you. And whoever is sharing the slides, you can go ahead and do that now. And I believe Dr. DeLucia is going to get started.
All set? Okay, thank you. Okay, so basically I'm going to provide a small a number of topics about what this virus is that's causing the current pandemic. And as you well know, we can see that I suggested it was basically spiky balls, okay, of virus that are causing this disease at the moment, and we'll be describing exactly what is inside, what is this virus about, and what is inside of it, and what are some potential places that we can attack it for now and in the future. So, can we have the next slide, please? Okay, so we're going to be discussing what are these viruses, where did they come from, and how are we going to interfere with them causing harm now and in the future. Next slide, please. Okay, this is a typical cartoon of a virus that we're dealing with right now at the moment. And what it has is it has an RNA genome, a ribonucleic acid genome, that is described by this little, in this cartoon, is this long string here that has these balls of protein that are closely associated with it that are called nucleocapsid proteins. And that protects the RNA within the virion structure that we'll be talking about shortly. This RNA genome has a considerable number of genes. It's the largest RNA genome of the RNA viruses, so the ribonucleic acid viruses, those viruses that use RNA as their genome to encode and also express the viral genes that are critical for making more of itself or reproducing itself inside a cell. The rest of the structure is that can be seen here. There's a membrane that surrounds this RNA genome that is derived from the cell. When the virus is leaving the cell that it's infected, it actually takes and picks up part of the membrane from the cell. And within that membrane, which is from the cell, there are a number of viral proteins that are jutting out of that membrane, out into the environment. And the most classic, or the one that makes this virus give its name, is called the spike glycoprotein, or S gene, in the virus, and we S for spike. And it's a large projection out of the membrane of about 15 nanometers or in size. Remember, a nanometer is a billionth of a meter, so we're talking about very small, but yet in the viral world, actually fairly large projection. And that's where it gets this virus family, coronavirus or Coronaviridae, gets its name because of that crown shape, or coronos is Latin for crown, and that's where this crown shape comes from. These glycoproteins, virally coated, jutting out of the viral membrane that encases the viral genome. Also in this membrane are a number of other proteins that may have some importance, at least experimentally. There's an M protein and an E protein, and perhaps also protein that may be of interest is a hemagglutinin acetylesterase glycoprotein. We know in the famous influenza virus that there is a neuraminidase that juts out of the viral membrane, and that actually is the basis, the attack of that protein is the basis for Tamiflu and Relenza, okay, that can actually inhibit that protein from functioning, and that protein is very important for the virus to leave cells, infected cells. And so, in fact, we're not absolutely certain yet, but we may have a way of attacking this protein of this virus the same way as influenza. If we can find inhibitors of this acetylesterase, it may in fact reduce the effectiveness of this virus leaving the infected cells, just like in the influenza case. We're early, it's very early in experimentation for that. I'll describe a couple other places where we're have some potent enzymes actually being, potent places that are actually being attacked at the moment. Okay, so let me see here. Okay, so let's go to the next slide. Next slide, please. Next slide. Can you hear me?
Sorry, I'm frozen here. Just a moment.
All right, that's fine. Okay, this slide is depicting a standard replication cycle of the virus. Before I describe some of the details and why do we need to know some of these details, before I describe this, where did this virus come from? This virus is a member of a rather large family of viruses. Again, the coronaviruses are a large family of viruses that infect many different animals, including birds, and specifically the ones we're mainly interested in are those that infect mammals. And this virus, when we analyze the genetics of it, we have determined that is in fact most likely bat-derived from bats. And this was the famous SARS-1, or SARS, it's currently called SARS Classic virus. It was also came from bats, and probably through bats, a virus leaving bats to an intermediary mammal or animal of some sort that humans encountered in exotic animal markets in China. And we know that we're not certain of how we got this virus into humans, but the very first cases were in a seafood market in Wuhan area, and it's not clear if it came from bats. There were no bats at that market, but in any case, the virus probably passed from a bat. Was a bat coronavirus that was able to infect other mammals, which then encountered humans and was able to infect humans. Now, a quite interesting point regarding this virus is that it had a couple of mutations that were developed within the bat. Okay, as it was just infecting the bat, it had a couple of mutations that allowed it to bind with fairly high affinity this receptor over here. This little black figure here represents a cellular gene and protein called the ACE-E2 for angiotensin converting enzyme 2 protein. And that's there for completely different reasons, not to bind a virus, but the virus has taken advantage of this receptor. In the medical world, it's important for blood pressure. The virus just so happens by accident takes advantage of this receptor being in a wide variety of cells, and that spike protein, that S protein, heavily glycosylated protein that is found in the outer viral membrane interacts with this ACE-E2 protein. And it turns out that the mutations allow this which originally was a bat coronavirus, to infect our cells with greater affinity than would be suspected from a virus just jumping immediately out of an animal to humans. So unfortunately, that was just by accident, but it happened, and that's how this virus sort of filters down into our lower respiratory tract. Dr. File is going to be talking about that, and affects us with relative efficiency compared to other zoonotic transfers of viruses from animals to humans. In any case, this interaction is critical. Okay, so the interaction is required between the virus and this receptor. It's brought into the cell by a process called endocytosis, which allows the virus membrane to fuse with the plasma membrane and enter into a organelle called the endosome. The endosome then actually becomes more acidic during that process. It allows for the endosome membrane to merge with the viral membrane, uncoating. We call it uncoating, which basically what this means is it unleashes the RNA genome of the virus into the cell cytoplasm, which is an important event. Some of you may have heard about hydroxychloroquine or chloroquine. This has multiple effects on human physiology, but one of the cellular effects is that it sort of inhibits this endosome acidity and potentially the conformational changes necessary to allow for the fusion of the endosome envelope with the virus envelope. And so it may be interfering with this uncoating step. We don't really know for certain yet, although we have found that chloroquine can in fact inhibit virus infection in vitro. Okay, so that's one place where it may work. It has multiple other places that it works, and so it's very highly complicated. And whether it's has efficacy or not, we will need further studies with larger numbers of individuals. After this encoding of the viral genome, okay, which is now in the cytoplasm, it immediately can be bound by ribosomes in the cell, which actually then begin to translate the RNA genome into protein. And the very first early protein is a polyprotein that is actually involved in making more of the viral genome. And that is these genes, these proteins over here are basically the RNA polymerase. Okay, so the virus needs its own RNA polymerase in order to recognize its genome and then turn it into many, many copies of its incoming genome. So a single RNA molecule in the cell then becomes thousands of RNA molecules under the power of this RNA polymerase, which it takes nucleotides and stitches, ribonucleotides, and stitches them together to make all the copies of the single genome that comes into the cell. Okay, so in fact, the reason why I'm talking about this is that this is a major experiment undergoing right now at the moment, clinical and also in laboratory, is that can we inhibit this enzyme?
No.
In fact, that's what
All right.
DeVere, in fact, has been found to inhibit. It's a ribonucleotide analog that the enzyme readily takes up and then causes a chain termination. Instead of completing replication of the viral genome, it terminates because it picks up this analog, nucleotide analog, and then stops the replication, stops the enzyme from further functioning, and therefore stops the virus from making thousands of copies of itself within the infected cell. So that is a very promising agent, which is so far has been determined to be very, very promising. And so we may hear more about that hopefully in the near future. After the virus, the rest of the details are important for a virologist because they may be other spots where we can in fact inhibit it. In any case, at the end of the day, all of the viral proteins and the nucleic acids that have been made, the genomes that have been copied, assemble and then are released. Thousands of viruses are released out of the infected cell into the environment. And we know this virus has a very high infectivity. In a day, an individual infected with this can produce maybe 700 million viruses or so in a short period of time and found in their throat and nasal passages. So this virus is very productive. One other final point is that this virus uses the membrane that surrounds the viral genome. It is derived from membranes that are found in the Golgi apparatus. That's where glycoproteins are actually that's where proteins are glycosylated. And this membrane is actually fairly stable, or more stable than the cell's outer plasma membrane, where many other viruses bud off. And this membrane may in fact the stability of this membrane may in fact make this envelope virus a little more stable than we're typically used to seeing, such as the herpes viruses or HIV. Those are or certainly some of the arboviruses, those are very fragile viruses, mainly because the virus envelope is not very stable. Whereas, unfortunately, this virus picks up fatty acids or lipids from membranes that seem to be more resistant to bile and drying conditions than typically viruses that have envelopes associated with them have. Okay, next slide, please. So in summary, there are many more details, of course, and once I get started, I probably could carry on for far more time, but we need to let Dr. File, in fact, get to the very interesting medical aspects of this virus. And so here's a small summary of what I've been trying to say. There are members of a viral family that are RNA-based genome rather than DNA, which is what our genomes are based on. They have a prominent viral-coded protein. That's the S protein or spike, and that gives its picture, that prominent picture of the viral proteins extending out into the environment, that crown-like shape, really rather distinct shape under electron microscopy that we see in many pictures of the virus. It also has a fatty lipid shell that must stay intact for the virus to be infectious. In fact, of course, detergents or soaps of any sort are very effective at destroying this virus, because what it does is it rips off the lipid shell, and once that happens, the virus is no longer infectious. Even if the RNA is intact, it does not matter. There are several points in the viral life cycle that we can attack to prevent its ability to infect or eliminate its presence once inside us. And at the moment, social distancing is the most powerful way to keep vulnerable populations safe until vaccines or antiviral therapy are developed. I must say that the latest data, one final point, the latest data has suggested that these viruses are although they can change and mutate, the viruses found in China, originally found in China, there have only been 4 or 5 to 10 mutations of viruses found in the United States. And that small number is very positive in regard to developing a vaccine against the virus. In fact, although it's stable in the environment, it's genetically, which is a problem, its genetic stability, okay, meaning that the genes stay the same over time, is actually greatly to our benefit of developing a vaccine that will be very powerful in stopping this virus from causing havoc potentially in the next year if we can develop an effective vaccine.
Dr. DeLucia, I don't mean to interrupt you, but we do have one clarifying question. Could you please repeat what the potentially very promising invention related to the transcription and translation is, please?
The remdesivir compound, I'm sorry, is that what there was?
I think
I'm
so.
reading, I think.
Yes, go, okay, so, yes, okay. So that drug is basically a nucleotide, what's called a nucleotide analog. It looks like the little bases, the components that make up our genetic material are called bases, okay, nucleotides. With the polymerase is an enzyme that stitches these together. And so you have to stitch all of them together in order to actually recapitulate our genes so that they can be passed off to our daughter's cells and our offspring. So viruses do the same thing. They have to stitch together individual bases in order to copy the incoming genome so that it can make many, many copies of its original genome that infected the cell. This analog is actually picked up by, it was basically first discovered with in Ebola virus studies. It was found to be actually effective against Ebola virus infections. So people immediately tried to use this with this virus, and they found some success. And what it does is the enzyme, which is a viral-coded enzyme, okay, so it comes from the virus. And so that's a good thing because we're not attacking something that's inside our cell. We're trying to attack something that the virus, it's specific for the virus, which helps the toxicity issues that could arise because these viruses are so intimately involved with the cell. In any case, by attacking a viral-specific enzyme or protein, this analog gets taken up by the enzyme and actually then is stitched in with the other bases that the enzyme is stitching together in order to copy the viral genome. And once it takes up this drug, this remdesivir, it basically can no longer stitch any more bases after that uptake. And so that stops the viral enzyme from copying the rest of the viral genome. And if you can't copy the viral genome, the virus basically becomes is forced to be extinct within the infected cell. It can no longer make more of itself and can no longer infect other cells. Or a progeny virus can no longer be made. Does that help? I'll be around to answer any other questions that people have. So let's go. We should probably move on to Dr. File, and then I'll certainly be around to answer any other questions that people have.
Excellent. Thank you, Dr. DeLucia. Go ahead, Dr. File.
Well, thanks, Angela, and thanks, Nicole. It's a pleasure to be with everybody to discuss this very significant pandemic, which has had unprecedented public health impact, of which we're all aware. And so what I'd like to do is discuss some of the clinical aspects. And so if we can go to the next slide, please. Angela has already talked about this as far as the identification of this infection or the virus in China, specifically Wuhan. I want to make a point, however, that, and he already mentioned that this is a large family of viruses, the coronaviruses. In fact, there are about 4 that have been commonly infecting humans for decades that usually are associated with mild respiratory infections. In fact, they're a common cause of the common cold, so to speak. But now we know that we have these novel viruses. I mean, SARS is one, MERS is a second one, and of course, the SARS coronavirus number 2, which is associated with COVID-19, which can cause very serious infections. And Angela already said it evolves from bats, but it probably went to an intermediate mammal, and I'm showing you a picture of one that is a likely candidate. This is pangolin, and these are animals that are eaten actually as delicacies, and maybe our representatives from Wuhan can tell us about this, but and are sold in these markets in China. But at any rate, we know that the cases have been accumulated. It's obviously a pandemic now. It's virtually everywhere in the world. I'm showing you data from March 22, but this is already out of date. It says globally about 300,000. We now know that's over 500,000 globally. The mortality from the latest data suggests there's about 4.4% mortality. But this also means that most infections are mild. And in fact, it's estimated that about 80% of the patients who are infected with this do not need to go to any health clinic or health facility. It's usually a self-limited infection. So we know that the clinical manifestations are variable. In fact, it goes all the way from asymptomatic infections to very serious infections. We do know, however, that those who have underlying conditions, and particularly the older, are at higher risk for severe complications. And I'm showing you in that sub-bullet point about the mortality, at least in China. If you were from 70 to 79 years of age, the mortality was 8%. And if you were over the age of 80, it was all the way up to 15%. Now, in the United States, again, 5 days ago, the cases were 27,000. As you're probably aware, now it's well over 80,000. The mortality is somewhat less. It's about 1.2 to 1.4%. But what obviously is we're aware now is the fact that this has sustained transmission within the community. And I'll talk about how that has implications for the communicability of this subsequently. We know it's transmitted primarily by air droplet, and I'll show you pictures of that, but basically this is the moisture that you might feel if you're within 5 to 6 feet of somebody who coughs or sneezes. The virus can be contained with these in air droplets. So if you're within that distance, you're at high risk of acquiring this if indeed somebody has that infection. Now, we know from other coronaviruses, the normal endemic coronaviruses that causes the common cold, that this can stay on surfaces for a while, such as doorknobs, such as keypads, or those of computers. And so we need to be aware of that. And that's why it's important to disinfect these types of surfaces very frequently. I already mentioned the possibility of asymptomatic transmission, which really is an issue when we consider how we can contain this. There is data that it's excreted in the stool. We don't know, quite honestly, if there's oral fecal type of or fecal oral type of transmission. Next slide. Now this slide on the first picture just shows somebody coughing. You can see the air droplets going into the air. And obviously if somebody's coughing and there's a lot of people due to close contact to that person, and if there's a high density of people, you can see how a lot of people in communication with that, or at least in close contact, can acquire the infection. And you know that it first started in China, but then we know that other places where there's a density of population, such as even in cruise ships, or obviously now in New York City, that there's a high rate of transmission. We know that the rate of transmission of this particular virus, the SARS coronavirus number 2, actually has a higher rate of transmission than the normal endemic coronavirus. That actually has a higher rate of transmission than seasonal influenza. There's this concept called R0, which just really looks at the reproductive score, or a number of patients who are in close proximity to someone, how many of those people would be potentially infected. And that score is 2 to 4, which means that every patient who's infected is likely to infect somewhere between 2 and 4 other people. Now, if you compare that with seasonal influenza, it's usually only about 1. So you can see how there's increased rate of transmission. We've already mentioned that it can be likely, in a way, transmitted by touching surfaces that are infected, and that there is asymptomatic transmission. Next slide. And so this just looks at a pyramid, if you look in the middle of this slide, of looking at patients who have mild or asymptomatic infection, more serious infection, and then obviously fatal infection. I want to compare this with SARS, which occurred primarily in Southeast Asia and China about 20 years ago, because in that particular infection, most patients who were infected, in fact, almost all patients who were infected actually became ill. And they didn't tend to transmit the infection until they became seriously ill. So this allowed for the termination of this epidemic, because if you quarantined everybody who was sick, then you essentially terminated transmission. On the other hand, if you have a large segment of the infected population who have only mild or asymptomatic infection, these patients may not be identified because it's so mild. Therefore, it's difficult to quarantine them, and that allows for increased transmission within the community setting. Next slide, and that's what we're concerned about at this present time. This is a pandemic, which simply means that there's evidence of ongoing transmission of the infection within multiple continents, and essentially every continent except Antarctica, I believe, now has cases, as you can see from this particular map, which is actually over a week old as it is. Next slide. Now, this is the first case that was reported in the United States. This is a patient who actually came from Wuhan. And as you can see on that shaded bar that has the numbers, this person traveled from China, from Wuhan. At first day back at work, he developed somewhat of a cough. The next day, some fatigue and some fever. Eventually, on the 4th day after coming back from Wuhan, he went to an urgent care center because of his symptoms. I'm going to show you a chest x-ray in just a second, which really was quite clear. And so he was sent home. But however, on that day, because of the concern that he had came from Wuhan, where there was the epicenter of the outbreak at the time, he was tested for this particular infection, and that eventually became positive. He was subsequently then admitted to a hospital the next day. You can see on day 6, the second day of hospitalization, he actually developed a fever. He had other symptoms, as you can see on that bar graph below, such as nausea, vomiting, diarrhea. This person was treated with one of those investigational drugs that Angelo mentioned, remdesivir, and he eventually improved and was able to be discharged. I actually am interested in this case particularly because the infectious disease physician who cared for this patient actually contacted me on the day of admission on January 21 of this year, and informing me that he actually had admitted the first patient, at least, who was documented in the United States. Next slide. And I'm just showing you the x-rays of this patient on day 4. This is when he went to the urgent care center. I mean, it's a clear x-ray. He really had no evidence of infiltrate or pneumonia. And on day 9, you can see next to it, he does have sort of a patchy infiltrate in the middle of his left lung there next to the heart. But it wasn't really all that impressive of an x-ray. Next slide. Now, this is the results of 2 studies of patients who were infected with the virus and causing COVID-19, first from Wuhan, where the epicenter was, and then secondly from another province in China. And I just want to compare these because there is some differences here. Although both of them I put in bolded, if you look at both of them, they primarily all had, or at least a great percentage had fever, and a great percentage had cough. You can see the age up on the top row from Wuhan was slightly older than that from the other province. And I point that out because the people from the other province mainly were traveling to Wuhan. They tended to be younger, and they tended to be less comorbid conditions, because if you go down to the very bottom, you can see the mortality was different. I mean, in Wuhan, it was 4%. Indeed, if you had to go to the ICU, if you had a severe pneumonia due to this virus, it was 11%, whereas in the other province, it was 0%. I also want to point out a couple of features, because this is what we're seeing now, even in the United States, that patients who present with this infection tend to have a normal type of white count. It's not elevated like you would see in normal bacterial pneumonia. Then the other point is I've highlighted the results for procalcitonin. Now, procalcitonin is a biomarker that allows us to have some differentiation between viral and bacterial infection. And most of these patients had a very low procalcitonin, which suggested that this was viral and not bacteria. Next slide. And a very common feature that we look for is CAT scan findings. And it's typically, as shown here in this slide, bilateral ground glass type of infiltrates. And when we see this, we are quite concerned about the possibility of patients that we're seeing now having this particular infection. So these are the patients we're targeting to do the testing specifically. Next slide, please. So once the virus obviously became into our country, the first thing we wanted to do was try to contain it or to control it or reduce the spread into our country. And so we did that, as you're probably aware, by travel restriction. The administration actually put a restriction on people from China at the end of January. I think this did have some benefit because it reduced the speed with which the infection did come into our country. We then were quarantining patients who had come from China, and therefore who potentially could be infected with it. We quarantined them for 14 days. And as you can see at the bottom of the slide, now we've obviously changed the epidemiologic association with travel to the point that it's not just China, obviously, actually Italy, Iran, Japan, South Korea, now essentially all of Europe, we consider it a concern. But now I say parts of the United States, but now it's basically all of the United States has some degree of community spread. But obviously, primarily now the concern is New York. So early in the course of trying to contain this, when we would see patients like in January and February who would come from particularly China or Italy later, what we had as a slogan in our infection control department was we would want to identify, isolate, and inform. That simply means that everybody that came to our healthcare facility, we would ask them about travel, their travel history. And if they have traveled to any of these areas, we would isolate them. And then we would inform our infection control, and then we would consider doing testing to evaluate if they had this type of infection. When we isolate, we'd have to adhere to standard precautions, and you've heard about PPE, and I'm going to show you that in just a second. But that's the concept of control. The next slide, however, you know, now we're transitioning to the fact that we know it's in the community. We're no longer able to stop it from coming in. It is in the United States. It is in our states. So what do we have to do to try to reduce spread from persons who are infected to non-infected persons? Well, first, we want to do good health practices. And you've all heard about hand hygiene. Since we know it can be on surfaces, we want to disinfect those surfaces, but we also want to wash our hands frequently, avoid touching our face, avoid sick people if at all possible, to disinfect surfaces, as I mentioned. And then we have the mitigation policies, which is social distancing, which simply means, since we know that the primary route of transmission is person to person, and it's usually within a 5-6 foot distance, if we can increase that distance of interpersonal contact, we know that we're going to be able to reduce the transmission. Since we know it's in the community, since we know that there's a certain percentage, we don't know how high, it may be a large percentage, but since we know that there's a certain percentage who are infected and are asymptomatic, we almost have to consider that anybody could be infected now. So that's why we have to reduce our contact to everybody so that we reduce the transmission. And of course, this is the concept that I'm sure you've all heard about, which is flattening the curve. Because what we want to do is reduce the speed with which new cases occur. Because as you've seen in New York, as we're seeing in some other areas, now even in the Detroit area, there's been a rapid increase of new cases that really overwhelms the healthcare system, and we want to avoid that. So if we can do this social distancing effectively, we can reduce the speed of new cases, we can blunt that curve, and that's what we're trying to do so that we're not going to overwhelm our healthcare systems. Next slide. And I want to point it out, it's very important. You've heard about personal protective equipment. Do we have enough? It's extremely important for all of our healthcare providers that now that we're all seeing patients, that we protect ourselves. I mean, our mission is to care for patients, but we have to do it safely. And we can do it safely if we use adequate personal protective equipment and we use it effectively. So you're aware of the need for gowns, the need for masks or respirators, the needs for goggles or face shields, because we know that if you're in close proximity and those air droplets go into your eye, they can get into us as well. We need to use gloves. So it's really important that we have the availability of appropriate and effective personal protective equipment for all of our healthcare personnel. And doesn't matter what the role of that healthcare personnel is. Could be a nurse, could be a physician, could be a respiratory therapist, could be a dietitian. We just need to have safe, effective equipment so that we can care for our patients and still be safe. I'm just showing you on the right-hand part of this slide, myself actually being fit tested for one of these N95 respirators. So it could, because we have to make sure that we know how to fit these so that they're going to work very effectively and keep us safe. Next slide. And I think this is my final slide as far as how do we manage patients now that we are seeing them. Well, primarily it's supportive. Angelo already mentioned some of the potential agents that we might use to reduce the amount of virus. Remdesivir obviously is an antiviral agent that actually reduces the replication and therefore, as he said, the ability for the virus to replicate and infect other cells. This is investigational. It's undergoing investigational trials right now, clinical randomized trials. And so we'll know the true efficacy, hopefully within a couple months on the basis of these trials. He also mentioned hydroxychloroquine, how it affects the pH balance. We do know from limited studies, and I have to stress that they're very limited, that it may have some benefit. But again, we need clinical trials to show the true efficacy. You all have heard about the development of the vaccine, that it's in phase 1 trials now. We hope that this will be effective so that we'll be able to use this just like we do the flu vaccine to reduce the burden of disease and certainly mortality. So that sort of completes my clinical assessment of what we know now about COVID-19 and the SARS coronavirus 2 infection. We still have a lot of unanswered questions such as what is the true incidence of asymptomatic bacteria, or I mean asymptomatic viral infection, and how long do we have to maintain this mitigation policy before we can feel comfortable about trying to get back to business as normal? Because obviously we're not as business as normal right now. So I'll conclude my remarks now, and I look forward to any comments or questions.
Thank you very much, Dr. File and Dr. DeLucia. That's a very thorough overview. We can stop the slide share now, and Jamie's been keeping track of questions throughout the presentation. So Jamie, what would be the first question to go to?
Hi, and thank you both for sharing such great information. And our first question is coming from Austin. And he states, similar to the 1960s respiratory syncytial virus RSV vaccine, an activated vaccine in which vaccine recipients did worse with more hospitalizations, ? And Austin, if there's any clarifying points to that, feel free to unmute yourself to help with that. And that was sent out during the didactic.
Yes, I can probably potentially comment on this extraordinarily complicated issue. Okay, so enhanced immune uptake is mainly most well known in the dengue virus family. Okay, there are 4 different serotypes of dengue virus, and when you're infected with one and then infected with the second one, you can actually get a worse infection, and that's been shown over and over again. And the theory is that it's immune uptake of the virus in an immune cell. Now, we don't, it's speculation at the moment. We have no idea, to be honest, until we do the studies. But the idea would be that this would not be, since there are many different coronaviruses, but there's only one serotype. It seems at the moment that is actually the cause of major disease presentation. The FDA, in fact, approved just recently the use of antibodies from surviving patients for passive immunity in order to take care of people and try to mop up free virus in patients with severe disease. In other words, you inject antibodies from these patients that have survived coronavirus into patients that are really struggling, and then that hopefully will neutralize or basically prevent the virus from continuing to infect that individual. If immune enhancement was evident, that type of passive immunity would not really be permitted, I would think. Okay, so that's one issue. The other issue is, again, there's not distinct serotypes as of this time. So the vaccine approach is probably still extraordinarily valid approach in prevention. There are some other issues, though. The protein that is a major protein for vaccination that will be used in vaccines is extraordinarily heavily glycosylated, which means that it may not be as simple as some people are suggesting. So we have to do a lot of work yet. And that's when Dr. Fauci and others are trying to caution the idea that at least a year, if not a year and a half before a vaccine that we can trust and will be developed. I hope so. I hope that answers. I think there's less risk for immune enhancement with this virus, but again, it's dangerous to make that conclusion without the real data.
Thank you, Dr. DeLucia. And our next question is from Melanie. Is it a true assumption that if someone gets the coronavirus and recovers, then they are likely to be immune and therefore less likely to get it again? Or does it depend on if the virus mutates or if there are more strands like the flu?
Yes, I can also potentially answer that. Of course, we have limited knowledge. So the initial results from the Chinese studies have indicated that there's not a reinfection a quick reinfection. Okay, so that's the good news. The uncertainty, though, of whether we can be reinfected by a mutated virus that's slightly different than the virus that's currently circulating, we don't have the answers at this time. But we do know that a reinfection immediately after recovery is not. There's decent data that suggests that's not going to happen. And that also leads up to the idea that a vaccine could, in fact, be a very valid approach.
Thank you again. This question is for Dr. File. Could you please respond to why those who have clinical high suspicion, as opposed to getting random samples with the limited test spas to understand prevalence and incidence?
Well, I'm not sure exactly what they're referring to, but we do have right now a limited capacity of testing. So we have prioritization, and certainly we follow the Ohio Department of Health recommendations of who we test. And basically those are patients that are sick enough to come to the hospital, that have pneumonia, have the characteristics of this, and that's who we're testing. The patients who do not have to come in the hospital because they're not that sick, from what I mentioned before, which is about 80% of the patients, these patients generally, unless they have significant risk factors, are going to do well. It's usually going to be self-limited, and usually within a week they're going to be significantly improved. So because we have the limitations of the test, we're not able, we're not testing those patients right now. Now, in order to define actually the extent of the infection in the community, it would be nice if we could start doing screening of many people within the community. That would help us perhaps define what percentage of these patients have asymptomatic infection. But we're probably not going to know that until we have good antibody tests that allows us to do prevalence studies to look at surveillance within the community. Because this is what was interesting about the SARS infection, is that when the investigators went and looked at people in China who were in, let's say, the Guangdong province, where actually SARS originated from, it appeared that people who were not sick did not tend to develop antibodies, so they probably were never infected with the SARS virus. This is obviously different here with the SARS coronavirus number 2. But right now, because of the limitation of testing, and I'm hopeful that within the next couple of weeks, we'll be able to be much more liberal with our testing. We're going to get much more information about this, and perhaps the percentage of patients who have very minimal infections or are asymptomatic will get a better, clear picture of that segment of the population.
Thank you, Dr. File. And our next question, and I appreciate everybody chatting their questions. I am trying to get to as many as possible, but just so that you know, if we happen to run out of time and if we don't happen to read your question, we are saving all of these questions and we'll be responding afterwards so that we can get everybody answers. The next question is in regards to PPE. Why isn't it a regular surgical mask considered sufficient if there is not a respiratory procedure or otherwise aerosoling activity occurring?
Well, actually, we do consider that a regular surgical mask on a patient is effective. I mean, if you're talking about the patient wearing a surgical mask, if we're not doing a aerosol type of procedure, a surgical mask and a shield over the face is going to be very adequate, along with gowns and gloves.
Thank you. And our next one is any commentary on resource allocation decisions when ICU beds and vents are in short supply?
Well, we're very carefully assessing all of our ICU beds, our ventilator supplies. We're getting additional amount of these from the national stockpile, as well as our pandemic influenza preparedness supply as well. So right now, we're assessing that we can increase our number of patients significantly without having to have a shortage of ventilators or ICU beds. I mean, we're using contingency plans that we're able to convert regular rooms into hospital ICU type of rooms. We'll have enough of ICU physicians that will be able to monitor these. So we're hopeful that we'll be in a good position when we start to see increasing cases come about.
Okay, the next question I have here are, why are patients with lupus being denied their hydroxychloroquine medicine?
Well, that should not happen. I mean, as you may be aware, the Ohio Pharmacy Board issued a rule just last Sunday that pharmacies are prohibited from filling prescriptions for hydroxychloroquine unless there's absolutely a documented test positive for COVID-19 or for the SARS virus, number 2 virus, that they have to have a physician order, that they will only fill a 14-day supply, and there's no refills. So that patients who require hydroxychloroquine because of rheumatoid arthritis or because of lupus should not be denied those medications. And so I think with this restriction, that hopefully will maintain the supply so that those patients who require it for other indications will have that available to them.
Thank you, Dr. Farrell. I have a question. I know we have a number of primary care providers on here, and there's a question from Laura Barr asking, can you comment on recommendations for primary care docs diagnosing over the phone? What they've been hearing is so far to presume diagnosis and act self-isolation for patient and quarantine for the household with a wide variety of symptoms, including atypical ones. Can you provide some guidance?
Yeah, that's true. I mean, we're trying to do a lot of virtual visits right now with, and we have here at SUMA a standard virtual visit screen. And if patients do have respiratory symptoms, like I said before, we almost have to assume that anybody that has respiratory symptoms, that there's a high likelihood it could be due to this. Very interestingly, over the last week, we've essentially seen the incidence of flu dwindle significantly. So we're not seeing the flu like we did even 2 weeks ago, which would confound the issue, because 2 weeks ago we were recommending to primary care physicians, if you had flu-like illness, just treat with the flu over the phone, because that was a high likelihood it was due to flu. Now that's not the case anymore, because we've really seen a reduction in the incidence of influenza. So what we're recommending is to go through a sequence of questions that could define, does this patient have high risk for complications? Are they older, have risk factors, immunocompromised or whatever? If they're not, and they're not having severe shortness of breath or cough or fever, they should be able to be treated just with symptoms at home. We're recommending that you use Tylenol rather than ibuprofen or non-steroidal anti-inflammatory agents, because there's limited data, and I will stress limited, that the NSAIDs may not be good for patients with COVID-19. Also, we're recommending not to use steroids, which sometimes is used in patients with a cough. Excuse me, I've got a cough, just a minute. But at any rate, we're recommending that if they're not all that sick, as the questioner said, just stay at home, self-monitor and quarantine themselves, and usually they're going to get better for 7 days. And if they're afebrile for 3 days, and it's been at least 7 days before their onset of illness, they can come out of quarantine.
Thank you, Dr. File. You ended up answering another one of the questions that had come in. And we're going to go to, has anyone have any recommendations for the crash cart being contaminated during code? Throw away everything or clean and let it sit for a few days. Someone has also mentioned keeping the code cart outside of the room. Could our experts please speak to this?
Well, that's a good question because certainly we want to maintain efficacy if there is a code called so that there's a cardiac arrest. We want to make sure that that patient receives adequate and appropriate emergency response. And I'm not sure exactly what we're doing right now with that. I'm not sure we've even had that that incidents occur, but certainly we would want to make sure that anything that would have been contaminated would be decontaminated before it's subsequently become available for use.
I might say the stability of the virus in the environment has been studied. There's been one decent study from the NIH that indicates the stability of the virus in various things like cardboard 24 hours, plastic, steel 2 to 3 hours, copper 4 hours, things like that. But I have to also state that these stability studies are taking the virus from that surface and then putting it into a cell culture system that is extraordinarily, exquisitely sensitive to virus replication. So we have no idea, to be honest with you, whether we can extrapolate from those studies to studies of virus in the environment, and then how readily we'd be able to pick it up from the environment. Obviously, we know that we can. So as Dr. File mentioned, extraordinarily importance of hygiene is critical. But it is also, one final point is that the virus can be destroyed effectively with soaps and detergents. Okay, so that's a critical point. So you don't need to be throwing everything away necessarily, but you need to be cleaning things properly and effectively.
I was going to say that at my hospital, we are actually keeping the carts outside the room and passing the meds to the individuals inside the room.
So I have a question that I'm trying to pull together a couple questions from the chat box to direct at Donnie and Jessica. So there's some CDC guidelines, and I guess part of the question is directed at the entire panel, and the other piece is more directed at Donnie and Jessica. But there's some CDC guidelines that are based on, the first question is, are they based on the actual length of viral shedding and the likelihood of passing on the infection? The follow-up to that is, how can we get young people who are not necessarily at the highest risk to take the virus seriously and prevent them from going out, so engaging in the social distancing?
I'm sorry, can you repeat that question for us?
So it was a two-part, and maybe we'll go to the second part first, that how do we get people to take the virus seriously and encourage people to engage in the social distancing and the self-quarantining at home?
Let's see. What do you think? It's hard to say. I think that people will often do what they're going to do. It seems it's hard to convince people to take it seriously. I think at this point, maybe they are. I mean, they're kind of forced to stay inside, but yeah, it's hard to say. I mean, I noticed at our university down here, the day after the universities were shut down, I happened to drive past the downtown area with the bars, and everybody was out celebrating St. Patrick's Day. So, you know, it's just hard to get young people to do that. I'm not sure how. I really don't know how to get them to take it seriously, to be honest. But anything?
Right. Like in China, the governments were taking a lot of measures to prevent people to go out and be socialing. And like, I think as far as the US government is doing, I think they're doing great because they're only allowing the essential business like being able to people. But and also I think people should have like kind of like a guidance to follow. Like I understand it's hard for people here to have like one standard, or like in China, because most of people will be listening to the government, and like the government will be podcasting like what should the public be doing on the TV. So like all the generations will be listening to them. But here is I feel like it's kind of hard, but
yeah,
I don't know.
it's hard to get people to do things that you want them to do,
Right.
honestly. But yeah.
I mean, like masks is like a good example here, because like everyone in China is like wearing masks right now when they're allowed to go out. But here, I don't know. I haven't seen one single person wearing a mask here.
Yeah.
And sometimes I wonder, like, if someone starts to wear a mask here, will more people start to do so? I don't know.
Maybe.
Yeah, I don't know.
Yeah, we don't have a great answer for that. Sorry.
Well, thank you. I mean, thank you for, for giving us your thoughts. And I mean, I encourage the other panelists to also jump in with any suggestions on how to get people to take it seriously. And related to the masks, another question that had come up in the chat box was related to masks. Should the guidance be to wear masks if you're not sick? Because that's not what the US guidance has been so far, but what is really the best practice to keep everybody safe?
Well,
And
Nicole,
I also,
So I can wait, Tom, for a second. Just the first part, you can come in on the second part. I would suggest that there's speculation, although it's pretty, maybe, I don't even know if it's valid to talk about, but some of the issues in Italy and Spain are potentially due to the social interactions, the close social interactions that are typical of those cultures. So if we take that as a lesson and perhaps use that and the severity of the situation in those cultures, that we in fact can bring that to home to some of our people here, that it is in fact a necessary component to flattening the curve, as Dr. File has shown us. And I think that's potentially a very important issue that needs to be continually described to individuals, that we will suffer severe consequences if we don't take these things relatively seriously. And I'm sorry, Tom, can you talk about the other point that was raised?
well, I was just going to comment about the use of masks in people who are well. I mean, the purpose of the masks are to reduce the amount of droplet spread from somebody who's sick. So if you're wearing a mask, it's really for somebody who is sick to reduce the amount that would go out into the 5 to 6 feet from that person. If you're well and wearing a mask, that really doesn't reduce as much of your exposure if you're within 5 to 6 people or person who somebody is coughing without a mask. So it's much more important to put masks on patients who are potentially sick than the person who is well. And so I just wanted to address that issue. And then the other issue is, I think there was the question about how long you're shedding the virus or whatever. I mean, we do know from patients who have been followed, particularly in quarantine, that usually, and this is for patients who have not received any of these antiviral agents, that usually it's about 10 days. It can go a little bit longer. There's very rare, I mean, in China, I know that there were some patients that were potentially shedding virus, at least it was detectable. That doesn't mean it was transmissible, but detectable up to about 20 days. But I also want to point out, when I said earlier that for persons who have respiratory symptoms and you're just going to treat them or at least evaluate them by a virtual visit over the phone, these patients we're not testing, but we're assuming they could have COVID-19. But if they're not tested and they're not positive, then, and if they're better within 7 days and then 3 days being afebrile, we feel comfortable saying that they can come out of their self-monitoring situation. On the other hand, because I don't want to give mixed messages here, when we send patients home who are positive, we recommend that they be quarantined for 14 days from the onset of their illness, because we know that if we're documented positive and they were sick enough to be in the hospital, they could be shedding for 10 to 14 days. And so there is a little bit of a difference of the duration of the self-monitoring or quarantine based on the fact that we're just empirically recommending that they self-monitor because of symptoms, but they're mild, versus patients who were sick enough to be in the hospital and therefore, and had a positive test, because these patients tend to be shedding more. And that's why there's a little bit of a difference in the duration of recommendation.
I also wanted to speak to kind of that psychosocial component, right, of what we're dealing with our concern for family members and just educating our children about this process. You know, I think it's that hard point. There's a lot of unknown factors that we're still kind of, you know, figuring out as a community of people, and how this is affecting us, and different things change on a daily basis. But I think what's really important is recognize that the concern, I don't know, you know, if they would agree or not, but just I think the concern is more for others' safety, right, than for ourselves, that we could be spreading that virus. And then it's for those that were, you know, who are more vulnerable, that are at that risk. So educating a child about, like, you know, you may feel okay and but what you may not know is you may be passing something off to someone who is more vulnerable. And so that's what we're doing, is trying to protect them. And that is just one aspect. We don't want to incite fear in our kids, so that then we come out of this in a month and a half and no one wants to talk, you know, and socialize or what have you. So we have to be careful to kind of mitigate that extreme, just taking reasonable precautions, so we don't flip to the other end of things where it could get pretty out of hand, where it would then be detrimental to our mental health if we're being overly cautious.
And Joan, it looks like you've been wanting to say something, so I'd like to give you an opportunity to add to the conversation.
Sure, yeah, so a lot of the panelists covered some of the things I wanted to say. I think from a public health standpoint, it's so important to keep the message often and keep it consistent. So I think one example was Dr. Acton, how she kept bringing out that flattening the curve graph, and she showed it over and over and over again to really drill that point home about how important that is. And so that's something that, you know, I think we all need to just keep bringing that point home. It takes a while sometimes, especially to get through to people who think they aren't at risk. And then also, I think I've been a little bolstered because I think we've seen a big shift over the past 10 to 14 days from spring break and the St. Patrick's Day, where people were really going out, where you're starting to see some of the kids that were saying on spring break that made it in the news and said, oh, if I get it, I get it, it's no big deal. I know one of those kids apologized on social media. So hopefully we're getting through to more and more people, and it's becoming more of a serious situation. And I think people are recognizing that.
Thank you, Joan. And I don't know if you can speak to this question as well. With regards to flattening the curve, where is the U.S. when comparing the current case curve versus the U.S. capacity line?
That I can't speak to our healthcare capacity in the U.S. and where we're at. I know Dr. Acton at the press conference yesterday talked about with their modeling, they feel like the curve is flattening in Ohio at least. I know one thing also that we need to take into account as we flatten the curve is, you know, to look ahead, because I think residents are going to push to lift some of those social distancing actions that we have in effect to keep the curve flat. So we had back in the influenza pandemic in 1918, they looked at data from different cities and their public health interventions. And St. Louis was a city that was very proactive, but as soon as they started to see improvement where the mortality rates went down, they tried to have school go back in session, and they stopped some of the gathering bans, and then they had a secondary spike. So part of it too is these public health interventions that we're doing, the non-pharmaceutical interventions like social distancing, we need to keep those in place. We're not sure how long yet, but for an extensive amount of time past when we start to see improvement.
Thank you, Joan. And one other question, and I see Jessica and Donnie, are you still there? We wanted to say thank you for sharing. And there was a question in there of how is your family doing in China?
Okay, well, I'll let you do that.
Thanks for asking. My family is doing well. Like, no one in my family has had it yet. Well, I believe they are not going to have it because like they're still in a lockdown. Yeah, they're doing great.
Good, thank you very much. There's a question from Patrick. What drug therapy do you recommend for moderate or severe COVID-19 patient presenting to the hospital?
Well, I guess I can answer that, and maybe Dr. Mystery can follow up as well. But you know, right now for patients who have mild illness, we're not recommend. It's just all supportive care. We don't recommend specific antivirals because remember, we don't have any proven antivirals available right now. You know, a lot of people want to use hydroxychloroquine, but we have to stress that while this drug has been used for decades for other indications and we know about the relative safety of it, it does have some potential significant side effects. I would say probably a third of the patients we wanted to put hydroxychloroquine on, there's relative contraindications, mainly because of heart issues. So we have to be aware of that. So we have sort of a protocol. I mean, a lot of institutions have protocols based on the relative risk factors, you know, age and underlying conditions, the types of severity of the pneumonia based on the oxygenation levels, and then some other laboratory tests which would indicate are these patients at risk for developing severe complications of their coronavirus infection. Those patients are the ones that were more likely to put on hydroxychloroquine, and we may or may not even add an antibiotic called azithromycin, which at least in very limited and extremely limited studies tends to just suggest there may be some benefit there. And then of course, I think the drug for which I'm most interested in is the one that Angelo mentioned, that's remdesivir, which is a specific antiviral agent, and at least in vitro has been shown to stop viral replication. Randomized clinical trials are ongoing right now. There has been compassionate use in the past, but there's been so much request for that now I think the company has had to stop that. They may be providing expanded access in the future, and so that would be the drug that if we have patients who are fairly sick and in our intensive care unit, as soon as possible, we would like to consider using that drug. But I have to stress that, remember, we still need the clinical trials to show that these drugs are really safe, number one, and effective.
Great, thank you so much, Dr. File. This next question I think is for Dr. Wayne. In light of the problems that we're having in the nursing homes, do you have any suggestions for residential care centers, especially where residents stay and staff rotate in and out?
Yeah, thanks, Emily. It's a good question. I mean, we have talked about some of the data that we're seeing, and obviously knowing that as folks that are older that have multiple comorbidities have worse outcomes. I think earlier someone mentioned that, you know, if you look at folks over the age of 70, the mortality rate jumps to 8% and 15% over the age of 80. The preliminary data and this is preliminary, so it's very early to understand the impact in the nursing home. But what it looks like is that if COVID is in the nursing home, there is a risk of infection of about 60% of the nursing home. And this is data coming out of Seattle. It looks like around half of those would at least be appropriate. Now, again, sometimes advanced care plans don't support going to the hospital, but it looks like about half of those infected would ultimately be appropriate for hospitalization, and then the mortality rate in these nursing home residents is upwards of over 30%. So I just mentioned that to understand that folks there are so vulnerable. It's likely the big reason why they're living in a nursing home. So they're kind of a litany of things that we're doing in an attempt to prevent the virus from coming in. We've unfortunately, and this is now national, we're restricting visitation. So from a quality of life standpoint, that's a horrible thing, but there really are no alternatives. So by restricting visitors, obviously that's an extreme social distancing. We're also, and this is pretty typical across the board, but I could certainly talk to what Communicare is doing. We screen our staff daily. So for symptoms, we screen with a temperature check when they come into the building. And obviously any symptoms or temp or exposure, then we ask that they quarantine at home. We screen our residents on an every shift basis. We're doing temperature checks daily, assessing them clinically on an every shift basis. And I think that actually what we found is that that's actually improved identifying early change of condition. In regards to docs, nurse practitioners visiting the nursing home or even students, I've tried to walk a fine line, and here's the thing. What we don't want to do is make our residents in the nursing home or make our staff in the nursing home feel abandoned. So we have certainly, to the extent that we have docs and nurse practitioners who are committed to coming in, we want to do that in a safe way. So we would screen them in the same way. Obviously, any symptoms, fever, then we would ask them not to come in. We've asked them to try to coordinate or minimize. So what we don't want is each doc or each nurse practitioner going to 3, 4, 5 different facilities. So to the extent that they're in groups, try to coordinate so that one nurse practitioner is in one nursing home, another tries to focus on another nursing home. So limiting the amount of touches, but certainly when appropriate, allowing folks to come in. For right now, it's a fine line. I would actually, I will tell you, I would probably opt for not having students in, only from the standpoint of, again, we want to limit touches, limit the risk of exposure. And the other piece is that we are 100% fully supporting the use of telemedicine. So what a great opportunity with the government loosening some of the regulations around telemedicine and allowing our physicians and nurse practitioners to connect to our teams in the nursing home to support our residents, leveraging telemedicine.
Thank you very much. And as we're getting close to the midpoint of the hour, I want to remind everyone that we will have a survey that we ask that you fill out so that we can get some feedback. There is a link to it in the chat box, and I believe you'll receive it by email. For those on the phone, if you have questions that you've not been able to ask, please send them to neomedecho.edu. And for any questions that we don't get to, we will try to get answers from all of our panelists and then share a full text document of all of the questions and answers. I do want to jump to a question that was asked before we do run out of time. Are there any protocols for other fields that are not necessarily working in the hospital or primary care settings? So mental health, addiction, homeless service providers who are encountering people daily, even potentially even going into homes. Case managers at community mental health agencies might be going into homes. So is there anything that they should be doing to best protect themselves?
I can speak to that. I know that CDC has issued a wide assortment of documents for guidance for different professions. So if you go to the CDC website under the coronavirus section, they'll have a listing, and then you can check and see if your profession is covered under those guidelines. But I know there's numerous guidelines out there for different occupation settings.
Excellent, thank you. Jamie or Emily, do you have another question that's high on your list?
I will ask one more question, and this one was for Dr. File on any idea on how this will affect M4 students who are about to begin residency. New York is now asking / may mandate that M4s to begin working early. Was just wondering what the national discussion and thoughts were on this. And we do have a lot of our students here with us today.
I know this has been under discussion by the graduate education committees and the education committees here at SUMA as to how that is going to proceed. I mean, right now we're excluding residents, and so this is going to be an issue. I mean, I'm hopeful that at least by the time of the next M4 beginning of the year, which would be usually June or July, that the curve would be such that to the point that, you know, it's not going to be an issue to have them avoid coming into the hospital, because it's extremely important for them to get patient education, direct experience for their, you know, for their education. So we're hopeful that by that, within a, you know, couple of months, we'll know what we'll be able to do with our residents next year for sure, at least starting in June or July.
Excellent, thank you. Probably one of the last few questions, depending on the length of the answers, but how can we make more telehealth services available to those people that don't have the physical hardware or knowledge on how to use that kind of stuff? So the patients that we're all trying to work with, if those patients don't have access to a computer and can't get to the library, are there ideas on how we increase that access?
Well, you know, the CMS has even allowed, or they've waived a lot of their regulations as far as HIPAA rules and, you know, security rules or whatever, to allow us even to just use regular telephones now. And so we've been conducting a lot of our, what I'm going to call virtual visits, and actually they're reimbursing us at a telehealth amount by just using telephones. And as long as we document in our electronic medical records, I mean, the only thing obviously we can't do is a physical exam, but we can certainly go through the other parts of our evaluation as far as, you know, history of present illness and review of systems and evaluation of laboratory tests, et cetera, et cetera. So that is being, because most patients at least would have access to a telephone.
Thank you very much, Dr. File. Thank all of you, really. And I think we might have time for one more question, but again, I want to take the time to thank all of you for joining us today, all of our panelists for answering questions, for putting together the presentation, for every one of you for showing up and contributing your questions and suggestions and many good links. We will pull all of this together. And with this being a very stressful time for everyone, our patients, all of us, students, colleagues, we're going to be offering a second session next Wednesday at noon. So that's April 1st, specifically on dealing with the stress, anxiety, and possible mental health issues that are going on for not only patients, but ourselves. There's a lot of transition in healthcare right now for not only the individual providers, but other team members. So we want to make sure that we have that session also to be able to address, you know, those more specific concerns. So if there is a last question, I'll kind of leave it out there for anyone, and otherwise we can start to wrap up and let Jamie finish with any last minute announcements or things that I might have missed.
No, I think you got it all. There are still quite a few questions. So what I will do is I have saved the chat and we will send that document around for all of our experts to weigh in, and we will distribute that afterwards. And you did cover everything. I did put the link in the chat box for where you can find the link to sign up for next week's session, which is the Project Echo Coping with COVID. So we hope that some of you can join us again for that.
And even though it's been noted in the chat box, we have recorded this session. There was not a patient case, so we will be able to release the entire recording. So we will be able to post the recording, the slides, and then once we have the compiled answers all together, a transcript of the questions and answers for everyone. And for those who weren't able to join us today, those will be available to them online too. Thank you all very, very much.